are at an increased risk of developing solid tumors and blood cancers. Much of the work in this area has been led by Dr. Savage, the chief of the clinical genetics branch in the Division of Cancer, Epidemiology, and Genetics of the National Cancer Institute. Her research work has led to a better understanding of cancer risks in TBDs, helping improve prevention and surveillance strategies while looking towards better treatment. During this talk, Dr. Savage will discuss cancers and TBDs. So thank you so much.
So we're going to change gears a bit, obviously, and we're going to talk about cancer in the TBDs. This is really focused mostly on understanding screening and cancer screening and what it is and what we all can do to help diagnose cancers early in the TBDs. So coming back though to the beginning is, I think, regardless of what's going on in your own family, we all know people who have been affected by cancer. And I just want to put this up there that age is the most common risk factor for cancer. It goes up as we age. This is just a graph based on US population level data that shows that as we age, getting to 40, 50, 60, the rates of cancer start to climb, okay? So it's something that everyone's at risk for. But what we're talking about here is in the setting of a genetic predisposition to cancer. I like this slide to really show again that cancer predisposition due to your underlying genetics is very complex and you're not alone in this realm. So our entire branch at the NCI, we study people at high genetic risk of cancer, and this is just a picture that shows all the chromosomes, and that's not even all, but many of the cancer predisposition genes that we know are out there. Some are more common than others, of course. And then I also want to remind everyone coming back to telomere length and telomere biology. So I had a similar graph before. This just shows that wide range of telomere length. I put this up when I'm talking kind of more about the general population or telomeres related to cancer risk in general. But just like all of those features related to TBDs, with cancer risk, it's a complex interaction between our genetics. We all have rare variants, we all have common variants, we all have changes to our cells that happen as we age that are associated with different levels of disease risk, not just cancer, but other things as well. And then the environment, of course, is also a factor in the general population as well as in the TBDs. It's less well known in the TBDs because we just simply haven't had enough patients to study, but we kind of can take some cues elsewhere. So I showed this on Friday, kind of how I think about telomeres in the concept of carcinogenesis or development of cancer. So what we know very well is that as we age, every time a cell divides, our telomeres get shorter and shorter, and that's part of the normal aging process. It's also consistent with what we see in people with TBDs. It's just that y'all are starting out at a shorter telomere length than the general population. Telomeres that are too short, the cells are supposed to die. If they don't, sometimes the cells change kind of what they're doing. They can keep going despite having critically short telomeres and accumulate more mutations. Longer telomeres can also be an issue. I don't know why I'm on a timer here, but that's okay. Longer telomeres are also a potential issue, and there are studies of rare genetic disorders associated with very long telomeres for age that also appear to have an elevated cancer risk as well. So this is the main data slide I'm going to show, and I don't want it to be too scary because it's based on 197 patients with TBDs. And this was the update that Dr. Alter and our group did based on our cohort of patients after about 15 years of follow-up for people in our study. And I put this up there because I also want to emphasize how things have changed. So the first one is the risk of any kind of cancer for people with TBD. Now, when she published the very first paper about, that was around 2011 or 10, I think. When we looked at the risk of cancer in TBDs, it was actually around 11-fold greater than the general Now that we have more numbers, our statistics are better, and it looks like the risk might be more like 4 times greater. Now that's still an elevated cancer risk, and it's something that we need to think about. But I want to use that as an example to say these numbers are not set in stone, and we're learning a lot. And then we also have talked about throughout this whole time, there's this wide spectrum of TBDs, and not everyone gets everything. These are statistics and numbers that we can put up here. But what I do want to say is that cancers of the head and neck, especially the tongue and the mouth, the oral cavity, are an increased risk in people with TBDs, and we've spent a lot of time talking about myelodysplastic syndrome, bone marrow failure, and risk of leukemia as well. So, knowing that, we know there's an increased risk of these cancers, especially with people with TBDs. So what do we do? So I want to put up some definitions first. What is screening? So health.gov has this official definition of medical screening, which are medical tests that doctors use to check for diseases and health conditions before there are any signs or symptoms. Okay? My colleague, who's the director for the Division of Cancer Prevention at the NCI, he's kind of expanded on this, and I like this definition, is that screening are processes that include medical tests and follow-up care that healthcare providers use to find diseases and health conditions before there are any signs and symptoms, with the goal of intervening to improve health outcomes and quality of life. So this definition really goes to pretty much all of the cancers, not just cancer screening, but all of the medical management we've been talking about over the last few days, right? We're looking at identifying things early and seeing if by doing that we can improve quality of life across all of the complications of TBDs. I also want to emphasize, it actually comes back to, I'm really glad we talked about palliative care. Screening is a piece of that. It's not just getting a test and seeing what happens. It's really about providing care around that test and around what that patient needs at that time. So in general, for any kind of medical screening test, who should have a test? Okay? So the condition that you're testing for should be an important health problem, right? There should be ideally, there should be a treatment for the condition. Now that's a little different, of course, in TBDs. This is really a topic for like the general population. You don't want to screen a whole 100,000 people if you don't have a treatment for it. It's different in your setting. There should be a facility, a hospital, a place for diagnosis and treatment if you find something suspicious on your screening. There should be a latent stage of the disease. What that means is that it's a disease that doesn't come on all of a sudden. Because if something comes on all of a sudden, you're not going to pick it up even if you screened for it the week before. So it's something that is progressive that you can pick up early. There should be a test or an examination for the condition. That seems obvious, but when we step back, it's like, oh, we need to actually have the right test for the right condition that we're looking for. That's a lot trickier than it sounds as well. The test should be acceptable to the population, right? You know, it's got to be an examination or at an interval as well that's acceptable to the person who's getting that testing done. The natural history of the disease should be adequately understood. I will say that that's something over the last 1 to 2 decades we've really learned a lot in the TBDs about the natural history, and that's really was the basis for what Dr. Alter and I started back in when she opened our marrow failure study in 2002, is defining, because if we don't know what happens, we can't prevent what's going to happen. We have to define things, and that's where we were 20 years ago with the TBDs, and I think we've understand a lot about that. And there should be an agreed policy on who to treat. So if you identify a person with something, there should be some medical experts and understanding and kind of logic about who you're actually going to treat with whatever it is you find. So the typical types of screening tests are a medical history, family history is an important piece of that, physical exam, Laboratory tests, no specific laboratory tests or even medical imaging can vary immensely, right, based again on what you're testing for. And genetic tests, even figuring out what's the genetic cause of your disease is a screening test, because that helps us, again, understand why it's happening. So getting to cancer, what is cancer screening? So again, it's checking for disease when there are no symptoms. You want to find it at an early stage, if at all possible, because you have a better chance of curing cancer for the most part if you find it earlier. So examples of cancer screening tests in the general population, and I will say that these are standard screening tests that our adults with TBDs should also be having, would be something like mammography for breast cancer, right? We know that if we detect breast cancer early, we have a really good chance of curing it. Colonoscopy, I want to emphasize that it used to be colonoscopy in the US was recommended starting at age 50, and then every 10 years, it's been pushed back to age 45. So anyone who's 45 years and older should have a colonoscopy every 10 years. More often based on your family or personal history sometimes happens. And that happened because the epidemiologists have looked at colon cancer trends over time, and we're seeing an uptick in colon cancer in people in their late 40s, so they recommend pushing it back.
How often is it recommended if you have a normal colonoscopy at 45?
Right.
What's the recommended repeat?
So it's if your general population, it would be every 10 years. People with TBDs, it's a little hard, but I would still say most likely every 10 years, because this type of colon adenocarcinoma with polyps, usually we've not seen in patients. There are other cancers though, including the anogenital squamous cell cancers that tend to be more on the outside that people with TBDs are at risk for, but that's detected differently than the colonoscopy. HPV tests for cervical cancer. We'll talk a little bit about that as well. And then also we talked about genetic testing. So I will also mention HPV, human papillomavirus, is the cause of cervical cancer, and it's preventable, period. So looking back to what are evidence-based guidelines, so this is based on lots of data, for how do we do cancer screening and cancer susceptibility syndromes, and I will say that even for the more common rare diseases, we still don't have good guidelines. The only official cancer screening guidelines for cancer-prone disorders are listed here, which include breast cancer screening, colorectal cancer screening, and lung cancer and prostate cancer for certain populations. So these are official guidelines by the National Comprehensive Cancer Network, which is a group of experts from around the world who get together. They review the evidence and they say screening this way for this cancer is evidence-based on all kinds of data, and they put that together. The challenge we have in cancer predisposition syndromes is that there's often not a lot of data, and these are the more common cancer syndromes. So we have the current screening recommendations in the book, but again, it's really based on expert opinion. It's based on groups of folks like those in the back and us and others around the world kind of getting together and writing these chapters. And again, that's where we talked about participating in research is really helpful because data is really important. So I talked briefly at the beginning about the risk for myelodysplastic syndrome or acute leukemia. I'm not going to talk about screening for that. We've talked a lot about that already. I will say following your blood counts is really helpful. You need to know kind of where you started, and it's really helpful if you know what's been going on over time. A challenge is though with acute leukemia is that it's acute, meaning that you can have a normal blood test a month prior and have an acute leukemia. So that's a test that in the cancer predisposition world is really a disorder that's really difficult to pick up early. We also don't have evidence that picking AML up early makes a difference in outcomes. This is not in the TBDs, but in other populations. So that's really tricky. and that's where working with the hematologist is important. So I'm going to spend most of my time focused on a couple solid cancers. The anogenital cancers I didn't put in here, but people with TBDs are at increased risk for squamous cell carcinoma of the anogenital region, so the anus around the vulva for the women, and screening is basically working with the specialists in that area and identifying changes early. The same goes for head and neck squamous cell cancers, where physical exams are still our best bet. So what do I mean when I talk about head and neck squamous cell carcinoma? First of all, in the general population, it's rare, it's not a common cancer, but it's also not uncommon. There are around 30,000 or so cases in the US every year. It's typically associated with older people who have been smoking and drinking most of their lives, or chewing tobacco, that combination. Unfortunately, the survival is poor for the folks in the general population, and often it's because people are presenting with more advanced disease. In people with TBDs, we know that oral cancer risk happens earlier than we expect from the general population, and it can be very challenging to treat because of all the other complications we've been talking about. The areas that are different in the TBDs is, for the most part, the cancers we see are in the oral cavity, tongue, cheek, floor, the mouth, roof of the mouth. Not so much in the general population, it's more likely in the pharynx, in the back part of the throat and down here, although it does happen in the other places. In the general, I had this in another thing as well, in the general population, there's a strong connection between HPV, the human papillomavirus, and oral cancer, head and neck cancer in the general population. And that's one of the cancers, in addition to cervical cancer, that we can see trends starting to, hopefully they'll be declining as we get more people vaccinated against HPV. But we know very well in the general population there is a connection between HPV infection and oral cancer risk. We don't think that's the case in the TBDs. We've looked in just a few patient samples to see, and we haven't seen HPV in this population. You can never say never, but we think it's a different mechanism for risk in the TBDs. So warning signs for head and neck cancer include a lump or thickening in the oral soft tissue, a soreness or a lump in the throat, difficulty chewing or swallowing. This can be a little tricky because we know patients also have esophageal stenosis, right? So that's where getting that GI involved and taking a look down there if someone's having symptoms. Trouble moving the jaw or tongue, ear pain, hoarseness, changes in your voice, swelling, these are more advanced. Numbness, those are all more advanced features. So what can we do about that? What do we recommend for head and neck cancer screening in the TBDs? This says annual, it really should be biannual dental screening. We should all be going to the dentist twice a year at a minimum anyway. We do also recommend that everyone with a TBD sees an ENT doctor once a year, ideally someone who has experience in cancer. The pediatric ENTs are great, but they're not ENT cancer docs. So an adult otolaryngologist is good. We do, as we talked about I think yesterday, recommend nasal laryngoscopy. That's they put that skinny little tube down the back, down through your nose, down the back, and you can get a really good look of the vocal cords as well. Follow leukoplakia, white spots for changes, and teach patients how to perform a monthly self-exam. And that's what I'm going to go through right now. So these are pictures of some warning signs. Leukoplakia, white areas, can also look red, can even sometimes look kind of brownish, hyperpigmented. A major challenge, though, in people with TBDs is leukoplakia is part of the definition of dyskeratosis congenita, right? So people with DC and TBDs often have these changes and they're not malignant. But we need to follow them, and you need to know what is like there and have an early threshold for getting seen early. In the general population, this would trigger a biopsy. It may or may not in someone with a TBD, and that's why it's getting to know your ENT doc, your dentist, and yourself in doing these exams. So the steps of the exam, oral self-exam is checking lymph nodes under your chin, looking at the lips on the outside, looking inside. Now we can get this literature, I think, adapted for the TBDs. So the Fanconi anemia research community now has a really nice video and how to take pictures and how to do this exam at home. And people can do it themselves in the mirror or have a family member or loved one also do this. So looking at the underside of both lips, looking along the cheeks, right, the insides, looking at your gums carefully, top and both sides of the tongue. Then something we don't often think about, looking underneath the tongue, in the floor of the mouth. So the bottom of the tongue and the floor of the mouth. Looking at the roof of the mouth, that hard palate, and the throat, which is hard to see back here, but looking at the back of the throat. Now again, it's complex, but if you do it and you make it part of a monthly self-exam, just like women are supposed to be doing a monthly breast self-exam, you can pick up changes, you can kind of map it now and see. We've had patients and families members who have sent us photos that they've been able to take just with their smartphones, and our ENT docs have been really helpful in helping us say, oh, that's fine, or yeah, let's get a biopsy on that. So dentists, again, like I said, are really important, and educate your dentist. I know I've actually, when my dentist has asked me, like, so what do you do? You know, I know you're a researcher at the NCI, and I explain, and he's like, oh, you know, he doesn't know what, because he's a community dentist, doesn't know about DC. Oh yeah, I see leukoplakia, but what do you do about it in this setting? So again, I think it comes back to, unfortunately, having to educate our providers. People with TBDs might have short tooth roots or widened pulp chambers, and that can sometimes cause some dental problems as well. So that's something that can be followed. Skin, I just want to emphasize, seeing a dermatologist yearly, I think is helpful. It's actually officially recommended by the American the Dermatology Association, their official guidelines. Early biopsy of suspicious lesions. The main skin cancers that we've seen in people with TBDs are squamous cell carcinomas of the skin. They can be locally invasive, so it's worth getting them out early. There are other types. There's melanoma, which is also related to sun exposure. If you have any changes in moles, those need to be evaluated. We haven't seen melanoma as a huge risk for TBDs, but it's something that we all have to consider as part of our sun exposure, which brings me to sun exposure and covering up, sunscreen, hats, avoiding being outside during those peak hours. Being aware, I know I've forgotten more than once about the reflective properties of water and snow, right? And we talk about avoiding tanning beds, of course, perform skin self-exams as well, and getting vitamin D from your diet, not from the sun. That's not your excuse. I need vitamin D, so I'm gonna go get some sunshine. It's no excuse. I will say this is one of my former boss, Margaret Tucker, who is a leader in familial melanoma research. So unknowns in TBDs and cancer screening. When do we start? So we're saying having a cancer screening around 10. We don't really know, honestly, though. We don't have strong data one way or the other yet. So we can tell you our studies and when we see it, but it's hard to know when to start. So again, it's sort of expert opinion, everyone coming together and agreeing. How often do we screen? We're recommending dentists every 6 months, ENT every year, skin exam every year, follow the blood counts based on all the other discussions we've had. How do you screen for cancer? We talked about the importance of physical exam. In some disorders, we do imaging. It's not quite so relevant for the TBDs right now. Hopefully, there will be some blood tests coming about. There's a lot of work. We could talk for a really long time about novel technologies that are looking in your blood and the serum or plasma to look for circulating tumor DNA as a screening tool. That's just at the infancy, but it's something that I'm hopeful we'll have in the future. Cytology, not just for the cervix and pap smear, but you can do the equivalent for the anal cancer gene risks as well, if there's any changes. And the real big question is does all this screening improve outcomes? Going back to that definition, sort of what does that mean? And is it acceptable to patients, right? We all live in the real world, and we want to make sure, we can recommend everything, but if it's not realistic, it's not going to happen. So what's best and how's it work in the real world? Things you can do to reduce your risk of cancer is, the first thing is get the HPV vaccine. The human papillomavirus is the cause of cervical cancer and a major cause of oral cancer in the general population. So even though we don't necessarily attribute HPV to cancer in the TBD population, if you can reduce your general risk, let's just do it. It's a very safe and effective vaccine, and the guidelines are here. Basically, it's recommended starting at age 9 for children, and then you can also do it in adults. There's specific guidelines from the CDC now. Additionally, these are things we all should or should not be doing in general. No smoking of anything. And no vaping, avoiding alcohol, eating lots of fruits and vegetables, being physically active, and those are, again, things that we have in our control that we can do. And that's all I have. I'd be happy to take more questions. I know this is a complicated topic.